Hello, everyone. Welcome. I'm Philip James, and today's guest is Dr. Julia Noel from Stanford University. Dr. Noel, welcome.
Thank you so much for having me. It's really an honor to be here.
And today's topic is an interesting one. It's protecting the nerves during RFA treatment. And this is an area of focus, at least when we go online and look at some of the information that your department has shared about RFA and even anything related to thyroid surgery. It appears there's a real commitment from your team to protecting the nerves when doing a procedure like RFA or even thyroidectomy. Can you share a little bit more about this commitment and actually relatively a lot of literature and video that you share with the public in regard to this topic?
Yes, absolutely. And I think that commitment really comes from, having a lot of experience and being dedicated to performing comprehensive ultrasounds for all of our patients that come into clinic. For providers that are starting to do RFA, I think it's first really important just to be comfortable with using ultrasound, identifying anatomic structures, identifying abnormal relationships, especially because the primary nerve that we're thinking about, which is the recurrent laryngeal nerve, is not one that's specifically visible on ultrasounds, but it does have a predictable location based on the structures around it. And so coming to this procedure from a place of really being committed to performing ultrasound and then also translating what we see on the ultrasound, into the operating room and doing surgery, which has been really helpful and helps us educate our patients about what to anticipate and also just what we're thinking about as we're going through these procedures.
So when a patient goes in for RFA treatment, is it risky? Is there a risk to the laryngeal nerve?
There is a risk to the laryngeal nerve. And so far, at least from the studies that have been published of thousands and thousands of patients, thankfully, it seems like that overall risk is quite low. And I think that has a lot to do with the targeted nature of radiofrequency ablation. We can be very specific about where we're treating. We can always see the tip of the probe on the ultrasound, so we know exactly where heat is being delivered. And although it's a risk, we can really minimize it just by being precise in our treatment.
And when you say risk, what does that mean exactly? Is if things were to go wrong, is the risk permanent or is it reversible?
Oftentimes it can be reversible. And I think one of the advantages to having patients be doing RFA treatment while awake or just under a minimal amount of anesthesia is that we can get real-time feedback if they have any voice changes. And we usually will check in with them every once in a while and just, ask them how they're feeling and how things are going. And then we can get at least a subjective assessment of their voice. And if there are any changes, we can often intervene right away. And that can result in almost immediate return of the voice or at least over the short-term recovery.
And you talked about ultrasound as a means to reducing risk. Is that the main tool to reduce risk, or are there other tools that you're using or devices to help minimize risk?
Ultrasound, I'd say, is the primary one, and just being really intentional and precise about where we're delivering heat and where we're doing the treatment. But the other part of that is some technique just in performing the procedure itself. We want to make sure that there's plenty of space to do our ablation that's away from any structures that we don't want to be touching. And so we can create that space by putting in some extra fluid, before starting or even during the procedure, just so that there's more distance between the area that we're ablating and, say, a laryngeal nerve or even a blood vessel that we want to avoid while we're treating.
Hmm. And really, the procedure is becoming more and more popular. So, when you did a presentation for Grand Rounds recently in April, you had reported that you had conducted 10 procedures, RFA procedures, but that number has increased significantly since then.
It has, yeah. And, just since that presentation, I think things have really, there's really just been a lot more awareness in the community about this as an option. So now we're well above 70 procedures and, booked out months in advance. And so I think it's just been a really exciting time to be starting this and to have patients, seek us out independently and also ask their primary care providers or their endocrinologists for referrals, which is neat because that also means that we get some more communication with those referring providers and if they have another patient that comes up who might be a good candidate, then they'll keep us in mind.
So, with the increase in the popularity of RFA, um, for a doctor who is considering adopting the procedure and uh, conducting RFA treatment for patients, what should every practitioner know going into this? Do you think they should know is a means to protecting the nerves or the laryngeal nerve?
I think really commitment to ultrasound anatomy is first and foremost. Again, because we don't always see the nerve, but we know where to anticipate it. And then just experience with doing ultrasound guided procedures. So that doesn't always have to mean jumping to RFA straight off the bat. If you want to
Mhm.
gain experience doing ultrasound guided biopsies or ultrasound guided, drainage of thyroid cysts, for example. Those are great ways just to get a little bit of experience to get the hand-eye coordination down of, manipulating an ultrasound probe and another instrument at the same time. And then, when providers do start doing this procedure, I think it is really helpful to have patients under a minimal amount of sedation or even just local anesthesia, just so you can get that real time feedback because you want to be able to intervene if something does change. And you want the feedback for your own learning purposes, to make sure that you're doing this in a safe way.
With the commitment to minimizing risk, what does your team look like during the procedure? How many are involved, and how is it different than, say, maybe other practitioners where maybe there's fewer people involved? Or what's the team setup like?
Yeah, and I think being at an academic center, the team is perhaps bigger sometimes. And we also have a number of fellows and residents who are often interested just in observing since this is a new treatment and it's not done very many locations across the country. But for the team that's actually necessary, I typically have one assistant, another MD assistant in the room, whether that's a colleague or oftentimes a fellow who is able to hand me equipment as the procedure goes on. And then often a medical assistant as well, who's sort of laying out the equipment, is able to go run and grab things if there's something we're missing, can take vital signs before and afterward, et cetera. So I'd say that's sort of the minimum is that you really need one or two extra people while you're, maintaining your own sterility and performing the procedure to be able to, you know, get equipment or hand you things that you might need.
When a patient is researching RFA procedure and where to have this done, um, there's a certain degree of diligence that a patient should probably do also to make sure that risk is being minimized. Um, what would you recommend as far as advice to patients who are considering this treatment? And what kind of questions should they be asking the practitioners to make sure that their best interests are being preserved?
I think that's a great question, especially because this is a new procedure and it's really hard to get a sense of, how experienced your provider might be in this. And truthfully, a lot of providers are just starting and so may not specifically have experience with RFA, but are still going to be very diligent and do an excellent job. And so I think general questions are, you know, do they do other ultrasound guided procedures or have experience with that? Um, what kind of evaluation do they require before offering a patient radiofrequency ablation? Um, what the plan for follow up is. Is the patient going to be following up with the provider doing the procedure, or do they have a team that will be doing their follow up ultrasounds and checking their thyroid hormone levels, et cetera? So I think those are really the big ones that patients should be sort of on the lookout for when they're seeking out someone for this treatment.
So even though this interview is really focused on RFA, um, it seems like thyroidectomy needs to be part of such an interview, right? With RFA, because in a way they overlap to a certain degree, um, and such a great thing about RFA, thyroidectomies are being avoided in
Mm-hmm.
a lot of cases. Is that the case? Are you conducting fewer thyroidectomies because of having RFA now is an option?
That's a great question. And I'd say the short answer is that I don't yet know, because I do think just the proportion of patients that we're seeing with these large benign nodules relative to the overall practice is definitely increasing. And so, whether these are patients who maybe would not have come to our attention otherwise, or these are patients who would have, and now we just have an alternative option for them, it's a little bit tough to say. But I do sort of get the sense that there's this whole population of patients who have just sort of been waiting in the wings for something like this to become available. And those are now often the patients that we're seeing an evaluation for this. But I will have to say that the nice thing about, the nice thing about offering this procedure in clinic is that I personally am not attached to offering, or convincing a patient to undergo RFA necessarily. As a surgeon, I'm also performing a lot of thyroidectomy procedures. And so I'm really more committed to offering the patient all of the options that I think would be appropriate for them, and then having them make the decision after they've thought about the advantages and disadvantages and what's right for them.
Hmm.
Um, I don't want to be a hammer looking for a nail, and
Mhm.
so it's I think it's nice just to be able to offer all of the options so that I don't feel like I'm trying to convince a patient of something that maybe isn't quite right for them.
Who's the ideal candidate for RFA?
Right now, at least in terms of how most of us are practicing in the US, it is someone that has a solitary, large, benign thyroid nodule that is either obvious externally, and or is causing them some symptoms. And most people that have large thyroid nodules, fortunately, don't necessarily have a lot of symptoms just because most of these nodules are growing pretty slowly. The body does an incredible job of adapting to that space expansion over time. But sometimes patients will have a little bit of trouble swallowing. They feel like something gets stuck halfway down. Um, maybe the quality of their voice is just a little bit different. Maybe when they
Mhm.
turn their head in a certain way, it's a little bit tougher to breathe. Or if they're exercising, they just can't get as much air or oxygen as they think they used to.
Hmm. Well, Dr. Noel, this has been great. Let's see. There's some questions that seem to surface each time that one of the interviews occur about RFA. So maybe we can shift gears to kind of a rapid fire question and answer. I'll present
I'm ready.
a common question, and let's see if we can just kind of breeze through these. What is the cost?
Depending on the institution, it'll be somewhere between $5,000 and $10,000 if there's no coverage by insurance.
Is treatment effective?
It is. Over the long term, most patients can expect at least 50% reduction in the volume of their nodule, and more likely somewhere between 70 and 85%.
Can RFA be used for malignant nodules?
It can be, and this is not an application that is used so commonly in the US now. We're sort of just getting started with this, but internationally, there's a lot of great data that's come out in the last couple of years showing that RFA is probably a really effective treatment for small thyroid cancers that are a centimeter or less in size.
Why did it take the United States so long to adopt RFA as a treatment option?
It's the million dollar question. um, the little that I know about FDA regulatory processes are very laborious. It is very time consuming. And I think that understandably, they really want proof that this is going to be effective, it's going to be safe, and it's going to add value relative to the treatment options that are already available.
Is RFA painful?
Generally, no. And we take a lot of care to deliver a lot of local anesthesia to make sure that it's a comfortable procedure. And that is one of the advantages of having, light sedation or awake patients, is that we welcome feedback about discomfort. And if patients are feeling discomfort, there are a lot of adjustments that can be made to minimize that.
What do you like about having RFA available as a treatment option?
I just feel like this is a procedure that fills this huge, what was previously a hole in our offerings for patients with thyroid pathologies, and especially these young patients with big benign nodules who really did not want to risk the potential of having to take thyroid hormone. I think that is the big value add, is the almost certain preservation of someone's thyroid function. And that's where this really fills a gap that we've had for such a long time. And, we know that there have been so many patients that have just been avoiding surgery, or maybe avoiding, seeing us all together because they just know that that wasn't the right decision for them. And they didn't want to run the risk of lifelong thyroid medication.
Dr. Noel, that's great. As we get ready to wrap this up, one thing I'd like to reverse back on into one of your responses. You said sometimes maybe insurance will cover RFA. Is insurance now, in some cases, covering RFA treatment?
It's unfortunately still really inconsistent, and often can be a process that if a patient's really motivated, or the insurance company just gives us the option to go through an appeal process, I'd say the success rate of that is still relatively low. But on a national and organizational level, we are working on trying to create a more streamlined process for this, just so that insurance may cover this in the not too distant future, I hope.
I hope so too. It's a treatment option that should be available to all. Because insurance will cover thyroidectomy, they should cover something that avoids thyroidectomy. But patients watching or listening to this interview from around the world, and they want to locate a practitioner who is offering RFA as a treatment, where can you send those patients?
You should definitely go to rfamd.com.
Another question. If you were to post something about RFA on a billboard, what would the billboard say?
This is a tough one. I'd say, let's see. I'd probably have a really big picture of a happy thyroid, uh, and it would say, um, keep your thyroid, try RFA, or maybe something to that effect.
I like the keep your thyroid part. And no need for thyroid replacement medication. Yeah.
Right.
Um, any final thoughts you'd like to share with those listening or watching?
I really just appreciate you having me on and being able to talk with everyone about thyroid RFA. It's something that, I've become very passionate about in the last couple of years, especially, as we're starting to see patients back for 1+ year follow up. And, as time goes on, I just become more and more convinced that this is such a valuable option for the right patient. And so,
Mhm.
um, I hope more people become aware of this. I hope people know that there's an option where they might be able to avoid surgery, where they can keep their thyroid and avoid thyroid hormone, and that this gains more national recognition so that, like we talked about before, this can become available to everyone.
And before we say farewell, where are your patients coming from around the country, or maybe even other countries? I don't know.
We do get a lot of regional patients,
Mhm.
but there are a fair number that come from out of state as well. And a couple patients have come internationally. So it's really a wide range. And I'd say for the most part, we see patients from California, but certainly neighboring states as well. And then the occasional international patient, just depending on circumstances or maybe where they have family in as well.
And for those listening and watching, all the links to Dr. Noel will be listed in the show notes, so they can find you there. Otherwise, Dr. Noel, thank you so much.
Yeah, thank you very much for having me. It was a pleasure.